Hello and welcome to the virtual Hot Topic Mentor Session, which is being shown live on the Alamo Breast Cancer Foundation Facebook page and also on the Alamo Breast Cancer Foundation website. I'm Carol Voss, your moderator for the evening. We are grateful to our funders for making the programs possible. ACR, Agendia, the Joe W. and Dorothy Dorset Brown Foundation, ASI, Exact Sciences, Genentech, Genomic Health, Merck & Company, Novartis Pharmaceuticals Corporation, Pfizer, Santa Fe Genzyme, Seattle Genetics, Veritas, and the San Antonio Breast Cancer Symposium. Tonight's session will begin with each mentor providing an overview of a specific topic or sessions. So be sure and post your comments and questions during the talks. Don't wait till the end, and they will be answered after all of our mentors speak. So before I introduce our mentors for the evening, we want to thank them for giving so generously of their time and their knowledge. We truly appreciate them, as well as all of our viewers, for your interest in expanding our knowledge of breast cancer and for your continued support of the Alamo Breast Cancer Foundation and our advocate programming at the San Antonio Breast Cancer Symposium. We're pleased to have three mentors join us this evening: Dr. Debu Tripathy, Dr. Steffi Oesterreich, and Dr. Matthew Ellis. So I wanted to give you guys a little bit of an introduction so that you'll know what amazing speakers we have in store for this evening. So first, Dr. Tripathy is a professor of medicine, and he's chair of the Department of the Breast Medical Oncology Program at the University of Texas MD Anderson Cancer Center in Houston, Texas. His clinical research focuses on the evaluation and development of new therapies in breast cancer, specifically growth factor receptor pathway targeting and biomarkers that predict sensitivity and resistance. He also happens to be the editor-in-chief of Bchir magazine, which I hope you all are reading. It's terrific. Our second speaker is Dr. Steffi Oesterreich. She's a professor of pharmacology and chemical biology. She's at the University of Pittsburgh Cancer Institute in Pittsburgh, Pennsylvania. She's also the director of education at the Women's Cancer Research Center. So her interests are endocrine resistance and metastatic breast cancer. And one of her focus areas is the understanding of invasive lobular cancer. So our last speaker for this evening is Dr. Matthew Ellis. He's a professor of medicine. He's the director of the Lester and Sue Smith Breast Center at Baylor College of Medicine, which is in Houston, Texas. He's a clinician whose research interest is the molecular profiling of breast cancer. He was also co-leader of the Cancer Genome Atlas Breast Project, and he continues to translate proteogenomic findings to improve the diagnosis and treatment of breast and other cancers. So with that, I'd like to go ahead and get started. So Dr. Tripathy, could you go ahead and give us your take on San Antonio this year and things that we should be aware of?
Well, thank you. It's a pleasure to be here again with all of you. I just want to make some general comments, first of all, about the pace of science, which is exemplified by what we have heard in San Antonio over the last few days. The good news, it is really picking up. Now, it's getting more complex, and everything that we are discovering is harder to decipher. But at the same time, trials are getting done faster. We're applying our technology for biomarkers more easily and on a greater number of patients. So the output has picked up essentially. And that is reflected in the approval of newer assays and newer drugs at a more rapid rate. So while there is still much more work to be done, it's really a pleasure for us to be able to report some of the findings here at San Antonio. So I will start with my insights on a couple of presentations mostly from today and one from yesterday as well, which I'm not sure if it was covered or not, but I'll start with that one. It was the RxPonder trial, which was a trial that was aimed at taking the expression profiles through an assay that's similar to many other assays that's available, RNA expression profiling, that basically looks at patterns of which genes are expressed and which ones are not in a tumor cell, and interprets that in a way that predicts the benefit of chemotherapy. And this requires that you start off by training the system in a way, having patients who did and did not receive chemotherapy look at the ones that recurred and didn't, and then go back and have a computer analysis help you sort out which patterns are associated with a response to chemotherapy and which ones aren't. It's basically pattern recognition. And if the techniques are done right and the statistics are done right, you should get an assay if it's really able to look at gene expression profiles. And of the commercially available ones, I think they all perform reasonably well as long as they've been trained properly. Oncotype DX is one that has been around for a long time, and it's commonly used for node-negative breast cancer. It's not clear if we can use it for patients with node-positive breast cancer, particularly the ones that are hormone receptor positive, which is where this technology is used, because here the big clinical question is whether or not adjuvant chemotherapy, that is chemotherapy given after surgery, will further lower the risk of recurrence to a sufficient point that it's worth actually taking the short and long-term side effects that accompany chemotherapy. So while we have been using this assay for node-negative breast cancer, it has not really been proven with a prospective randomized trial in node-positive breast cancer. So the RxPonder was specifically designed to look at that. They picked a mid-range score of 25 based on prior data, and the hypothesis here was that patients who had a score of less than 25 could, if we had a randomized trial that compared hormone therapy alone to hormone therapy plus chemotherapy, that it would be able to identify those who derive a benefit, and that the recurrence score itself would be proportional to the benefit from chemotherapy. The results of the study were a bit mixed. It showed that in postmenopausal patients, there didn't seem to be a difference in the recurrence risk, which is good news, at least based on what the trial was supposed to find, and that is that patients with a recurrence score under 25 may not need chemotherapy in the postmenopausal group. But in the premenopausal group, there actually was a difference. And we're still stuck with the question as to whether it was really the chemotherapy itself or whether it was the suppression of the ovaries, which we now know is also an effective way to lower the risk of recurrence. Some patients do have suppression of the ovaries with chemotherapy, and it could explain this effect. We really don't know between these two possibilities, and the fact that the overall recurrence rate is low in these studies, which is a good thing, makes it harder to decipher who is getting a benefit and who isn't. So I think that the results here are going to be controversial. In fact, Matt, Ellis, and I were trading a few comments earlier, and I think we agree on some things and disagree on others. But one thing that we might be stuck with is the fact that we cannot disprove that in premenopausal patients that patients with a low score can get away without chemotherapy. And part of it is because of the way the trial was designed. But the way most people are interpreting it, and I'm not sure I agree with this, is that if you're premenopausal and have positive nodes, remember this was specifically for patients with positive nodes, that we can now not use a low oncotype score to tell someone they don't need chemotherapy. I'm not fully sure that I agree with that, because there are other data sets that suggest that the benefit in these patients is marginal. So I think we're going to need to wait and see how the scientific and clinical community interprets the data. And I don't think it's the end of the story. First of all, I think we need longer follow-up from this trial. The number of events, the number of people that recurred wasn't a large number to have a robust statistical analysis. So I think we're still going to learn from this trial as the data comes in. So that's what I have to say about gene profiling. I'll just add that the whole idea of looking at both gene sequence and gene expression profile and protein analysis is a very important tool that we are now linking to all of our clinical trials as well as to other series. And we expect that the output of clinical trials now capturing that information is going to be more meaningful. Let me now move on to the area of immunotherapy. That is an area that's very exciting, and there have been some updates from two of the large studies using immunotherapy. Now, by way of background, some of you all may be familiar with this to some extent, but we know that our immune system reacts against many foreign bodies. It's, of course, designed to react against viruses and bacteria, but it also reacts against cancer cells because they are not completely normal. Some of the proteins that cancer cells make are either expressed in the wrong place or are mutated in some way, altered in some way, so that the immune system recognizes it. And we can show that the immune system is developing antibodies and T cells against some of these antigens, but it doesn't seem to be enough to affect patients. Certainly by the time they're diagnosed with cancer, it's not potent enough to wipe out the cancer, although it does happen in a few cases. Now, in pre-cancers, the immune system may be more active. We don't really have a way to know that because we can't track pre-malignant cells very well. But we do know that cancer cells can co-opt the immune system. They can actually manufacture substances that are designed to dampen the immune system because the immune system comes with a damper switch so that it doesn't overreact when we have an infection. A lot of the illness you see with COVID, for example, is not so much due to the virus as it is due to our own immune reaction against the virus. And that sort of exemplifies why our immune system needs a dampening system. Well, it turns out that cancer cells have learned how to co-opt that and signal through what are called checkpoints, a series of proteins and receptors that can downregulate the immune receptor. And the seminal discovery of this, which led to the Nobel Prize 2 years ago, led to the development of drugs that can actually counter these checkpoints, if you will. So revolutionized the treatment of certain cancers that are intrinsically more immunogenic, like melanoma and lung cancer. But with breast cancer, that has not so much been the case. Triple-negative breast cancer seems to be a little more immunogenic, and this is where we are seeing some results with checkpoint inhibitor therapy. Most of the trials have been in combination with chemotherapy because checkpoint inhibitor therapy alone doesn't seem to be very effective. So the initial trials about 1.5 years ago that led to the approval of the first checkpoint inhibitor were in the triple-negative setting. The first one was with a chemotherapy called nab-paclitaxel with or without a checkpoint inhibitor known as atezolizumab, and that led to the first approval. It showed that survival and progression-free survival can be extended, about 1/3 longer survival with these drugs. They're generally well tolerated, but they do have side effects that are important, particularly against the skin and the GI tract, causing skin rash and diarrhea, but less commonly can even affect the kidneys, the heart, the endocrine glands. So they do infrequently have very serious side effects. But a second trial was done that led to the second approval just a few months ago of Pembrolizuba, which is another checkpoint inhibitor, also in combination with chemotherapy. This trial was a little more permissive. It allowed both nab-paclitaxel as the chemotherapy partner, but another combination, carboplatin and gemcitabine, which is commonly used in triple-negative breast cancer. And overall, the positivity of the trial led to the FDA approval, but what was presented at San Antonio today was a breakdown of that trial by the different chemotherapy partners, and it confirmed or at least suggested that either chemotherapy with the checkpoint inhibitor is a good, effective partner. So we need to learn much more about how to use these drugs, in particular, whether we can use them in early stage breast cancer to prevent a recurrence in the first place. We would really like to be in a situation where no one ever develops metastatic breast cancer, even if they have early stage breast cancer. And so moving these immune therapies into the early stage setting is a high priority. One of the first settings in which this has been looked at is in neoadjuvant therapy. These therapies are used in patients who have larger tumors, and we use systemic therapy, either chemotherapy or even hormonal therapy, or now in the case of the immunotherapy trials, immunotherapy plus chemotherapy before surgery. And we look at the number of patients who have complete disappearance of their tumor at the time of surgery, since that is a benchmark that predicts longer-term survival. So one of the studies that followed this design is a study called Impassion 131. It looked at standard chemotherapy with or without atezolizumab, and did in fact show that the number of patients who had a complete pathologic response was higher. This follow-up study that was presented at San Antonio was one that focused more on the quality of life, because this is very important, not only toxicities, but just how patients go through the 4 to 6 month period of time when they're getting these therapies, and are they able to continue with their normal activities of life, and how does it affect their overall well-being. And this study that was presented by Beth Mittendorf, who's at the Dana-Farber Cancer Institute, showed that the overall quality of life was really not negatively impacted in any way in the group of patients that got the atezolizumab, the checkpoint inhibitor therapy. So that's a step in the right direction in terms of safety. Now, what we don't yet know from this study is, even though the pathologic complete response rate was higher, does that translate into fewer people recurring and more people surviving breast cancer? That endpoint still needs to be followed on this study, and another study that has also been completed of similar design but with a different checkpoint inhibitor. We need to follow the longer term outcome to see if this is something that we may want to use in earlier stage breast cancer. So this is an evolving story, and where the field is going now is trying to understand more about the immune pathway so that we can turn it on more effectively without having to use chemotherapy, or in other subtypes of breast cancer where we're not seeing this immunogenicity like hormone receptor positive breast cancer. So these studies are in progress, and you'll be hearing more about these in the years to come. So I think I will stop there. And we can certainly come back to these in the question and answer period, but I will stop at this point, and thank you for your attention, and I'll come back to you more when we have a chance to go through questions and answers. Thanks.
So thank you so much, Dr. Tripathy. And what I hope we're going to do later on is we're really going to have a vigorous discussion among the three of you on some of the topics that have been raised, because that's always my favorite part of Hot Topics. So next up, Dr. Oesterreich.
Yeah, good evening, everybody. It's really my pleasure to be here. I think the Alamo Hot Mentor session is always, for me, one of the highlights of the symposium. Obviously, I wish it would be different and not virtual, but, I'm glad at least we can do this. So what I did is what I usually do in these Hot Mentor sessions every year, is that I look at the presentations which were presented at the mentoring session, and then think, okay, where there's some really exciting science which I can explain as a PhD, and which I think has really clinical relevance. So I looked at the presentations from today, and I decided to go into the brain metastasis spotlight discussion. I think that was very exciting. I do think, and I'm sure everybody agrees, that brain mets remains a very, very critical topic. And I think there's an increasing realization of the very unique nature of these metastases, and that they need more attention. And I think that's reflected by having a unique and independent session specifically focusing on brain metastasis, which I thought was really great. So brief background, it's a devastating disease. 10 to 40%, it depends on the subtype, of breast tumors metastasized to the brain, more so in HER2, triple negative. And there was actually a poster from Dr. Warren from the Dana-Farber showing that there is also an increased rate of metastasis to the brain in inflammatory breast cancer. So unfortunately, this is very aggressive. The median overall survival is between 2 and 23 months. And for a specific subtype of brain metastasis, the leptomeningeal metastasis, the overall survival is even shorter, so they are even more aggressive. So in the discussion session, there were two discussants. It was Dr. Priscilla Brasianos from MGH in Boston and Dr. Carrie Anders from Duke, who presented a few of these brain metastasis posters. There were 3 posters focused on really basic translational and then 5 or 6 on clinical progress. And maybe I can summarize the highlights of these posters. So the first, I think it is, there is no doubt that molecular profiling of the brain metastasis has really taught us a lot over the last few years. And there was one poster from Dr. Cosgrove from Ireland, from Dublin, who has done in a large collaborative study with Mayo and actually our group in Pittsburgh, sequenced a large number of paired primary and metastatic tumors to the brain and looked what is altered in these brain mets. And Nicola Cosgrove presented that one of the biggest, most significant, impressive changes really was defects in DNA repair. So these brain mets, they look somewhat like BRCA1 or BRCA2-like tumors, although many don't have the mutation. So this has implications for potential therapy with drugs like PARP inhibitors. It also means there's also, as I'm sure some of you are aware of, that these changes in DNA repair result in mutations, which then sometimes result in immune infiltration in these tumors. So that brings up the idea that maybe at least a subset of these brain tumors might respond to immune therapy. We clearly need more work because in general, the idea, and a lot of the studies have shown over the last few years, that in general, immune filtration is lower in the metastasis compared to the primary disease. But again, maybe some of those which have these defects in DNA repair, maybe that's different. So we need more work on this. The poster also contains some data on changes in general molecular makeup. And I think there's now increasing evidence really over the last few years that approximately 20% the molecular subtype of the tumor changes. For example, and I think a great example is HER2, that 15 to 20% of primary tumors which do not express HER2, once they're in the brain and grow as brain metastasis, they are now HER2 positive. And this is clearly clinically relevant. Now you could think, okay, that means we need to look at the molecular makeup of each brain metastasis because, 1 in 5 changes and we have therapies, but it is difficult and clearly not feasible to do brain biopsies. Very often it's challenging and not possible. But the other possibility is to get access to CSF, and the CSF stands for cerebral spinal fluid, through spinal taps. And there was a very exciting poster, which was discussed in that spotlight session from Dr. Fitzpatrick and Dr. Claire Isaac's lab in London. So that group analyzed CSF liquid and looked at genetic changes. So they isolated DNA, looked at genetic changes, and they also isolated cells from that liquid. And they made a couple of very important observations. They showed first that the changes in the CSF liquid from patients with metastatic brain tumors is different to the DNA changes what you analyze when you do these what we call liquid biopsies from blood, from plasma. So that's very important. So the analysis of the DNA mutations or the altered molecular changes in the DNA from the blood is different. And if you want to know what happens in the brain, that doesn't give you the answer. So you really need to look at the CSF liquid. The other thing they did is they isolated cells from the CSF liquid, and they made models. So they take them, they put them into culture dishes, put specific media on, and they could grow them as three-dimensional cultures, what we now call organoids. So organoids, they look like little organs. And that's exciting because you can use that for drug testing and drug development. And they actually went a step further and took these little, I almost want to call like cell balls, like organoids, and put them into mice. And then they grew. And so you have models where you can study brain metastasis in live mice and animals. So this is a really, really important progress, because one of the problems is that we don't have enough models to study brain metastasis. So that was a very exciting poster. Talking about modeling, the other thing we need more is really we need more models to study and to study the blood-brain barriers. I think it is pretty clear from the molecular analysis that the brain is a sanctuary site. It is different, and a lot of the drugs can't get there, and we need to really understand why some drugs do, others don't, why the same drug in some patients do and in others don't. So that was Dr. Fitzpatrick's poster. I think very exciting about CSF. What for me personally, I also got very excited about, because I am very interested in lobular breast cancer, is that from their study, 48% of the samples they analyzed were lobular tumors. They specifically looked at brain metastasis in the leptomeninges. And there are some prior studies out showing that there's an increase of ILC in leptomeningeal disease. This is of interest. We do not know why that is. There is something unique about lobular tumor cells, that it migrates to or survives better on these, I call it like these slippery surfaces of some organs, like the leptomeninges in the brain, the ovary, peritoneum, or even on the bowel. So we don't understand that, and that I think is important to find out. They actually showed one case, which I thought was very interesting, which was a ductal tumor in the primary cancer. And in the brain metastasis, it was a lobular tumor. So maybe it was a mixed tumor on the primary, and then the lobular cells really grew out in the leptomeningeal brain metastasis. They didn't go into detail in this. So this was on the basic biology of the brain metastasis. Again, some very exciting progress with respect to molecular analysis and with respect to modeling brain metastasis. On the clinical side, which was summarized by Dr. Anders, she made a few statements at the beginning, which I just take the liberty to repeat. So one thing she said as a really progress is that the clinical trials, some of the clinical trials now studying response in brain metastasis include quality of life, which didn't happen in the past. So that was great. There are more and more studies where the brain metastasis is now included into clinical trial, which really allows conclusion, allows larger numbers. And finally, she also highlighted that finally there are some studies on delivery. Again, this connects to what I mentioned earlier. We need to have models to study the blood-brain barrier. But there are more efforts, and there are more studies on really better drug delivery to the brain. There are new drugs. They are being tested, and I will summarize this briefly. I think if there are more details on the clinical aspects, I'm sure Dr. Tripathy or Dr. Ellis would, like to comment and can comment on this. So there were two posters on a new drug called Sasi Tusa Map. This was presented by Dr. Brenner and Dr. Diarra. So this is basically an antibody which recognizes a protein called TROF2, and that's conjugated the antibody to a chemotherapeutic reagent. In these trials they presented, the response rate was pretty high, I think 30-35%. So there was a lot of excitement about this specific new drug. There was another poster from Dr. Hansen. He presented some studies on a new antibody for tumors which are defective in DNA repair. And I thought that was interesting because that really linked to some of the other studies showing that the brain metastases have, at least some of them have this DNA repair defect. The antibody, the name of the antibody or the drug is, I think, 3E10. And yeah, I think we should look forward to hearing more about this. There was another presentation, again, emphasizing that brain mets are very different. Dr. Shah, he showed that the response to therapy in neoadjuvant studies, and Dr. Tripathy talked about these neoadjuvant studies, is uncoupled from subsequent brain metastasis. So again, suggesting that what happens later on in the brain, because of the different microenvironment, these breast cells, they totally look different, they change. So you don't know it from the response in the breast, and we don't have a biomarker. We can't measure something to say, you know, okay, the likelihood of brain metastasis is high, and it's not feasible to do MRI or other imaging for everybody. So I think there needs to be more research for biomarkers to really predict the risk of increased metastasis to the brain. And I want to end with a poster in a study from Dr. Saura on a clinical study with neratinib. Neratinib is a small molecule inhibitor for HER2. So this is different compared to large antibodies. And they confirmed in the study that neratinib plus capecitabine is better than lapatinib. And again, I think Dr. Tripathy and Ellis can comment more on the detailed clinical aspects of that trial. So that was exciting. But again, what I thought personally was interesting for me with the interest in lobular breast cancer is that they had a small subset of leptomeninges where they also had very promising response. Again, small numbers, but you know, maybe you could speculate these were lobular tumors. They didn't share that information. At least I didn't see that in the presentation. But yeah, that was very exciting. So I think I would like to end here. I hope that gives everybody, you know, a nice overview what happened in the brain metastasis spotlight presentation in that session. I thought it was very exciting posters, and really increasing realization that these brain mets are different. We need to study more the molecular makeup. We now have more better models, and I think there's a realization that you know, they need to be involved in clinical trials, and I think overall there's a lot to look forward to. I think a lot of excitement, including on the basic research side. And that's it.
Thank you so much. And we've already had a ton of questions come in about metastatic breast cancer, including brain mets. So maybe we can dive a little bit deeper into that, you know, in the discussion section. So now, Dr. Ellis, you're up.
Hi, folks. I guess I have the last word, which is relatively uncommon in my household. I just thought I'd sort of ruminate a little bit, since I'm the last speaker, on progress, but also lack of progress in certain areas. I mean, when I first met my first breast cancer patient in the late 1980s, essentially there were only 2 or 3 drugs available. Tamoxifen was a new drug. and there were a couple of chemotherapies, and that was sort of it. And when you think about the landscape now, it's truly remarkable how innovation and molecular insights into the nature of breast cancer has led to multiple drugs in different subtypes of the disease. So there isn't time to go through a whole review of all the advances, of course, but I just sort of would point out that the advances in HER2 positive disease is extraordinary. There are these advances are driven by 2 monoclonal antibodies against HER2, and then became an era where we developed a number of small molecule inhibitors of HER2, of which we've heard a lot about. A new kid on the block called tucatinib, active in the brain, which is good to hear, although I don't think we're curing HER2 positive brain mets, but at least we're beginning to make progress there. And then these antibody drug conjugates, they call them, where the antibody targets the chemotherapy to the HER2 positive cell. So lots of advances there, and we can discuss that if people are interested, but lots of hope. Triple negative breast cancer, of course, used to be the red-headed stepchild, just was chemotherapy, and chemotherapy was surprisingly effective in a modest subset of patients. And for years we played chemotherapy rearrangement games and came up with modest improvements that way. But then along comes 2 things. Again, monoclonal antibodies, but this time these monoclonal antibodies are designed to help T cells, your natural immunity, to attack the cancer. And if the cancer does show signs that it's immunogenic because the T cells are there, then you can aid and abet those T cells by taking the brakes off the immune system and allow those T cells to kill the cancer cells. This is often done in combination with chemotherapy because the chemotherapy has an effect on the tumor cells. The tumor cells release their contents, and those contents are recognized as abnormal by the body, and more T cells form to eradicate the tumor. So I think there's a lot of hope there. And also, out of the blue, comes an antibody drug conjugate. This time has a completely complicated name. Was it Sasi Tusa Map govitecan, right? So basically, this is targeting another cell surface molecule. This time not HER2, but something called TROP2. And we saw some data that this drug is helping patients with triple-negative breast cancer, and has remarkable response rates compared to just straight ordinary plain Jane chemotherapy. And curiously, unlike HER2, there doesn't seem to be a threshold level on the cell where it's not effective. So in other words, it looked like, for some data I think presented by Dr. Hurwitz, that you didn't need to test for TROP2. You basically gave it and hoped the patient was a responder, which is often the case, but not always. So lots of progress in triple-negative breast cancer, aside also from information about PARP inhibitors that some of you may know about. Certainly it can be very effective in triple-negative breast cancer arising in patients with BRCA1 mutations. But I was looking for advances in EL-positive breast cancer. And remarkably, I thought that this was a disappointing San Antonio from the EL-positive breast cancer perspective, and let me explain why. We're getting very good at working out what not to give to patients with EL-positive breast cancer, certainly in the early stage disease. Debu was talking about that, right? We've worked out that there's a huge proportion of patients who don't benefit from chemotherapy. Unfortunately, that doesn't mean that bad things don't happen to them. It's just that chemotherapy can't prevent those bad things happening. So we need an entirely new pharmacology for EL-positive breast cancer, and we've been struggling with this for years. Remarkably, we're still underappreciating the importance of endocrine therapy, particularly in premenopausal women. When the responder trial was being born, I stood on the table and beat my chest and said, you've got to give ovarian suppression to the node-positive patients. Otherwise, you won't be able to sort out the conundrum, long-standing conundrum, of how chemotherapy works in ER-positive breast cancer. As Debu was saying, you know, the chemotherapy poisons the ovaries go to sleep, and when they go to sleep, the estrogen stops flowing, and that stops feeding the tumor. So you need to give ovarian suppression to the premenopausal women, better endocrine therapy, and then you might be able to de-escalate chemotherapy in the premenopausal women. Well, they didn't listen to me, of course, because no one does. You know, certainly not, you know, my daughter, but I love her to bits anyway. But the point about all that is we're left with this conundrum of what to treat people with. So when the ER-positive patients unfortunately relapse, we are not advancing the field as much as we would like to. Certainly, the CDK4/6 inhibitors are having an impact, and a very welcome impact on metastatic ER-positive breast cancer, but it's certainly not a curative approach. Resistance eventually occurs in almost all patients. It's a mixed bag when you use it in early stage disease. Palbociclib, which is a perfect good CDK4/6 inhibitor, does not have much of an adjuvant effect. In fact, in a trial that we were looking at this week, you could see that the adjuvant effect sort of appeared when the patients were on the drug and then disappeared when the patients stopped the drug. The patients, you know, the two curves came together. And that's because basically palbociclib and its friends, ribociclib and abemaciclib, they stop the cell cycle, so they stop the cells proliferating, but they don't seem to eradicate cells. So that's what we need to do. We need to eradicate ER-positive breast cancer cells. So how are we going to do that? Well, Debu again touched on this. The hopes for immunotherapy in ER-positive breast cancer are currently completely unrealized. We saw, I don't know if my co-mentors could find a trial of immunotherapy in ER-positive breast cancer. I could find one. And unfortunately, it was a negative trial with a protein called LAG3, which was supposed to increase antigen presentation in combination with chemotherapy. But the trial was pretty negative, except possibly in premenopausal women. And their explanation was that, well, premenopausal women have better immune systems, and that's why it was working. But that's an example, I think, of how hard it is to develop immunotherapies for ER-positive breast cancer. Although in our own profiling studies, we believe there is a solid subset of more aggressive ER-positive breast cancers that do have immunogenic genomes and should be targeted with immunotherapy, but you've got to identify those patients up front with proper diagnostic techniques. No antibody drugs conjugates for ER-positive breast cancer, although that fancy drug, Sasi Tusa Map is being tried in metastatic ER-positive disease, and I have no idea whether it'll be successful or not, but I think it does also show that we need to go back to the drawing board. We need to profile the surface repertoire of proteins in ER-positive breast cancer to find new things we can target and tag with chemotherapies. And I know there's a bunch of people that I'm talking to who are doing experiments like that. And what about other drugs other than CDK4/6 inhibitors? Well, of course, we've got new anti-hormonal drugs, which look like they could be effective in what we call ER mutant breast cancer, where the estrogen receptor recodes itself, so it becomes insensitive to the standard endocrine drugs. And there's a couple that look really quite promising. And I think those drugs, they're kind of like oral fulvestrant, but specifically tailored to work against some of these mutants. That's a promising field. So back to endocrine therapy, if you like. And then we're left with a smorgasbord of drugs targeting what's called the Pi3 Kinase Pathway. These drugs are remarkable for their toxicity, but they can't target mysterious proteins in the cell, signaling proteins in the cell, like something called Pi3 kinase catalytic subunit and AKT and mTOR, and they look like they have modest effectiveness at best. Several are approved for ER-positive breast cancer, and they can delay progression, but they don't look like they produce survival effects. Even the latest and fanciest and most targeted one called alpelisib does not elicit an overall survival effect. So what are we left with? Why is ER-positive breast cancer so difficult? Well, I think the answer is we're not making a proper diagnosis here. I don't mean we're mistaken. We know the patient has estrogen receptor positive breast cancer, and we know they're stage 4. But I think you have to work out, for each patient with endocrine therapy resistant disease, exactly what's driving that tumor. You have to work out what the DNA repair defects are. You have to work out whether it's immunogenic or not. You've got to work out what its cell surface repertoire is. You've got to work out what the signaling is that it's addicted to. And until we can do that one patient at a time, I think we'll see failure of trials which sort of group all ER-positive breast cancer together and then compare tooth-based A and tooth-based B, right? You're just not going to make progress that way. So for me, ER-positive breast cancer, having studied it for 20 years, remains a confusing nest of diagnoses that we need to put on our sorting hats, and get them into the right subsets to investigate. And there's no lack of patients, of course, with metastatic ER-positive breast cancer. As David Cameron pointed out right at the beginning of the symposium, this is the majority cause of death from breast cancer, not triple negative, not HER2 positive, but ER-positive breast cancer is what takes so many women's lives. And I think that molecular profiling efforts, particularly when we look at DNA, not just the DNA and not just the RNA, but all the proteins in a cell and all the ways those proteins are signaling, will allow us to come up with the right classification of the disease, which will drive therapeutic progress. So I'll stop there, because I know the most important thing here is the questions and the conversation. Thanks a lot.
Thank you so much. So we've had a ton of questions come in, which is really good because that means that our listeners are just hanging on your every word. So first question, and this is just going to be a very quick one, and then we'll take a more complicated question here in just a second. So one question that came in is, and this was from your talk, Dr. Ellis, they want to know what were the names of the drugs that you mentioned for triple negative breast cancer? Because apparently a lot of people missed it when you said the drug names.
Yeah, I think it was actually Debu who was mentioning these drugs. Well, there are 3 new drugs, really. I think you'd agree, Debu, that are sort of more targeted. 2 of them are these monoclonal antibodies that promote T-cell function. So one's called Pembrolizuba and the other was Atezolizumab. And there are a bunch of others that are in development and pending approval, I suspect. And then the antibody drug conjugate that targets TROP2 is Sasi Tusa Map govitecan. What's its trade name, Debu? What's the trade name for Sasi Tusa Map?
The trade name is Trodelvy.
Trodelvy, that's right. Trodelvy. I have to train myself not to use trade names.
With these names.
Well, it's Trodelvy. I think all patients with triple negative breast cancer, metastatic triple negative breast cancer, need to be tested. Need to have a shot at Trodelvy myself. Wouldn't you agree with that? Right now, it's approved for sort of patients who've gone through other lines of therapy, but they're doing trials that are bringing it forward right now. So, first line metastatic, and it's the kind of drug that you could even see being used in the neoadjuvant setting and the adjuvant setting. Was there a specific question about Trodelvy? You're probably doing it.
I agree with you. The randomized study that led to approval of that drug, called the ASCENT trial, showed a larger difference between standard chemotherapy compared to this antibody drug conjugate than we even see with immunotherapy. It nearly doubled survival. So that's a big impact. So I agree with you, Matthew. This is a drug that we may want to use earlier. And I think that in general, the antibody drug conjugates are giving us a lot of activity. The question is it going to persist? Are people going to still become resistant to these drugs? But what we're seeing at this point, including with the HER2 antibody drug conjugate, known as trastuzumab deruxtecan, or Enhertu is the trade name, that's also showing dramatic improvements compared to standard therapy for HER2-positive breast cancer. So I think antibody drug conjugates are here to stay. I think we're going to see more and more of them come on to into trials and into clinical use.
Yeah. Does that answer the question?
I hope so. It's much harder.
You got more than you bargained for.
I have my phone here and I'm trying to read the questions at the same time. So this is a little bit of a lag time here. So let me go on to another question at this point. And this one was asked by Tracy. And I think it's a very topical one right now. So she asked, there was a presentation this morning about HDAC inhibitors. The phase 2 data was very promising, but the phase 3 trial did not confirm those results. Doesn't this demonstrate exactly why FDA accelerated approvals should be minimized? So that's kind of in the news today too with the COVID vaccine. So anybody want to take a stab at answering that one?
Well,
I
will
go first, Debu, and then I have something to say about it too.
That's absolutely true. The reason we do large trials is to make sure that the uncertainty is as small as it can be. Keep in mind, when you're looking at a complex problem like biology and clinical medicine, there's never anything that is 100% true. We can only look at this in a probabilistic way. So when we say this drug is better than that drug, we can only say that the confidence in it is 98% or 99%. The larger the trial, the higher the confidence is. So sometimes you see something that looks really promising, and the FDA will do what's called an accelerated approval, which means, okay, this is not a definitive trial, but it looks good enough for us to at least offer this to patients who don't have other choices. But we're going to make sure that the larger trial is done and that we eventually report these results. And if it shows anything different or that it's not as good, then we're going to revoke the approval. That actually happened to a drug several years ago called Avastin, which had been approved for breast cancer. So the same thing is true with the COVID vaccine. You know, we're looking at early data from the Pfizer and from the Moderna vaccines, and they are showing about a 95% effectiveness rate, but that's still, quote, preliminary, and we don't have all the safety data. So this is really only a preliminary approval if it happens tomorrow or anytime soon. It's still going to depend on the longer-term data, and the FDA could yank the approval later. So I actually do agree that the FDA should approve things early, but still with very careful oversight and waiting for the final data to come through, and then making sure everybody's aware of it and making a final decision.
Okay. So let me help you. Let me help you out here a little bit with this histone acetylase inhibitor story, because it's really, really instructive. That was a really, really perceptive question. That's why it's very important when you're listening to the clinical trial presentations, you understand the phase of the trial and what the primary hypothesis was. And the other slide that's really important is the slide that tells you what the characteristics are in the 2 comparator or 3 comparator groups, looking for what we call imbalances. So in this particular trial, the primary endpoint was not positive in the phase 2, but they had this mysterious survival effect, right, in the phase 2, where the patients getting the active drug seemed to live longer. Well, that could be due to the drug, but it could be due to imbalances in the randomization, and imbalances are particularly a problem in small studies. We saw another example of this, actually, which I won't go into, of a small study of atezolizumab today. But the bottom line is, when they did a big definitive study where the randomization works better and is a definitive registration trial, it's big enough and properly powered enough, the hypothesis which was raised turned out to be incorrect and the drug didn't help. So the FDA would never have approved that histone deacetylase inhibitor, etinostat, on the basis of the phase 2 data because the primary endpoint was not positive. The second thing about what the FDA does is it looks at the situation that you're in. Is your house on fire, or can you wait and get more data? Well, the issue with COVID is the house is on fire, and there's enough data about safety, and there's enough concern about the poor folks in the hospital that are exposing themselves every day to patients with COVID-19 and sometimes dying as a consequence. Is that we must approve that vaccine, and all doctors and patient-facing staff at the hospitals must be vaccinated because it will save their lives. So we have to do that. Now, what other people will do outside that community, we'll see, and they'll probably wait longer for a bit more safety data. But overall, I think we do have examples where, for example, in third-line metastatic HER2-positive disease, the outcomes are terrible, and then along comes this new antibody drug conjugate, and it gets a preliminary approval based on phase 2 data. There is not even a randomized data, but the responses were remarkable. And so the FDA said, we ought to do a randomized trial, but we'll let patients access this because they're having a miserable time, and I think that's the right thing. So I think overall the FDA does a wonderful job. Those guys are super professional, and I think we can rely on them in general to do the right thing. Is that fair?
Yeah, maybe just one comment. As a scientist on this trial, I was actually, they did studies to show the drug is on target, right? They looked at acetylation and it actually showed it worked, yet the outcome wasn't what was expected, yeah.
Which makes it even more convincing negative result, right? Yeah. The pharmacodynamic marker showed that the drug was doing what it was supposed to do. Although there's other drugs in that field which might be more effective, and I don't think that that's a dead field. It could be that etinostat just not a very good drug or not doing the right thing biochemically or pharmacologically.
Yeah. Okay, I'm going to go ahead and ask a whole question that came through. So a lot of you have talked about metastatic breast cancer. There's a lot of interest on the program today about that topic. So if each of you could answer this. Kelly wants to know, what was the most important take-home for metastatic breast cancer?
I'll go last. Well, for me, if you like, since they're quiet, the continuing take-home message is metastatic breast cancer is an incurable illness. And that's a very, very, very tough thing to have to say to any patient with any kind of illness. And so I don't think that 15 years ago, the whole area of metastatic breast cancer was receiving enough attention. But increasingly, people are appreciating this is the Mount Everest, if you like, for breast cancer therapy. And I do think that there is a renewed emphasis on trying to find out exactly why the metastatic process happens and exactly how we should treat it and how we should engage the immune system. So I don't know. I think see what Debu and Steffi have to say, but I think that a cure for metastatic breast cancer, at least to some patients, is not as far off as we would think. Like, for example, metastatic testicular cancer is curable in 90% of patients. It's not the process of metastasis per se that leads to incurability. It's the fact our drugs don't work effectively.
So I agree with you, Matthew. I do think breast cancer is eminently curable. It's very hard to say at what point are we going to be seeing, large numbers of patients living a full life with breast cancer. I don't think we will eradicate it necessarily, but if we can train the body how to live with it in harmony, by whether it's immune or other types of mechanisms that we haven't even discovered yet, I think that is a more likely scenario. The fact of the matter is that we live with cancer all the time. There are constantly cancer cells being propelled towards cancer. It's a natural thing. It's survival of the fittest. If you think of all the things that can befall a cancer cell, whether it's a mutation, whether it's epigenetic silencing, that is turning off of genes, whether it's a variety of other adaptive responses that gives it a selective advantage, it is by nature going to result in an autonomously growing cell. It's sort of like pouring water down a mountain. Gravity, think of gravity as selective pressure. Water is going to flow down the mountain. It's going to follow all these different rivers and channels, which one can make analogous to mutations. And it's sort of a natural state of things. At the same time, our bodies have adapted to this and have developed mechanisms to wipe out these rogue cells, whether it's through programmed cell death, whether it's through an immune system. So really, we just have to learn how to tilt the balance a little bit more. And when someone actually does get cancer, have our body's natural mechanisms be augmented to the point that it keeps it in check over the lifetime of that person. And that, I think, is at least a framework that I think will allow us to make the discoveries that allow this to happen.
Yeah, no, I agree. And maybe I can just add on 2 points. One is, I think there were a couple of discussion sessions on modeling breast cancer. One was run by Alana Bellman and others. So the idea that we really need good models where we can test drugs and mechanism of action for metastasis. I mentioned something earlier for brain metastasis, but even other metastasis. I think for us as scientists to have models where we can study why do cells metastasize, why do they metastasize to liver, lung versus brain or others, I think that's important, and there has been a lot of progress. Actually, not only, and people pay more and more attention that you not only take, for example, mice, you work with mice which don't have an immune system, but also that we have model system now which have an immune system, so we can study really the complex interaction between two more intrinsic drivers of metastasis, but also the microenvironment. So yeah, I think the progress on modeling to study metastasis has been great. And then the other thing, there were a couple of talks on liquid biopsies, the analysis of changes in liquid biopsies. And this is both at mutation levels, and Dr. Ellis mentioned the ER mutations earlier, but also CTC, so circulating tumor cells. There were a couple on basic science that maybe not only the number of CTCs, but the way the CTCs behave in blood. For example, if they go as clusters or as single cells, might really matter for the aggressiveness of the disease. And there was also a presentation that really the number of CTCs and how many, actually, I'm sorry, I didn't explain CTCs. The CTC stands for circulating tumor cells. So that the number of CTCs is associated with aggressiveness of disease. So yeah, I think those two things, I think I got excited about further use of liquid biopsies and success in modeling metastatic disease.
All right, so Dr. Tripathy, in your last comments, you mentioned that maybe we should kind of change our messaging about metastatic breast cancer and not say that we're searching for a cure, but that, you know, this is we should reframe the way that we think about it to a chronic disease. Is that what I understand you to say? And if so, how can advocates play a part in that? You know, I mean, there's so many efforts out there, you know, for the cure, and we're going to find a cure by this date. So do advocates need to be providing the larger community with different messages?
Well, I don't know how it's all going to play out. Sometimes we can cure patients. Certainly with early stage cancer, many patients have surgery, they might get some additional therapy, and they live the rest of their life, and they're essentially cured. But we don't know that at the microscopic level they may have some cells still floating around and that are living with disease all their life. I think the way we need to think about it is sort of a messaging way that we may be able to turn it into a chronic disease, but one that is associated with a normal life, normal quality of life, and the ability to do what you would normally want to be able to do over the entire course of your natural life. So yes, I think that we have to think of it like any disease where you may still have it, but you're doing well with it. Eradicating it is one way to go. When you have an enemy, you can either try to get an army and fight a war, or you can negotiate and have a peaceful settlement. And I think we have to be open to both ways of attacking cancer. I just think that with very advanced cancers, that's a more likely scenario. So it has to be part of the range of possibilities that we might expect.
All right. Any other comments on that? Otherwise, we'll move on.
No, I think cure sounds good to me, but I think when I think about these problems, I wonder whether we as clinical investigators have got our strategy right. So, there's such a lot of emphasis in these meetings on clinical trials, but a lot of what I do is, I think you put it in the category of clinical investigation. Patients aren't necessarily on experimental drugs. They may be getting the standard of care, but I'm really trying to work out why things happen to people. And so I'm asking for a tube of blood, or when they're having a biopsy, can I have an extra sample to put it through this new molecular profiling technique to see if that predicts the outcome better. And I think we need to do an awful lot more work with patients with breast cancer. I think that mice and rats and all the rest of it are useful, and I certainly do a lot of mice and rats experiments, but I think there's no substitute for studying patients, maybe to get at some of the things that Debu's talking about. So, for example, for a while there was a lot of interest in looking at bone marrow, and Steffi mentioned samples of the cerebrospinal fluid. Certainly serial measurements of things in the blood are very helpful, increasingly sophisticated ways of studying that. So I think just studying women and asking them to participate in that kind of research is definitely something that the advocates can help us with, because there really is a gift. There's not necessarily anything to gain from the patient's perspective. They're not getting an experimental drug, but the investigators, really trying to make progress with understanding the disease, and I think that that's definitely something advocates can help with.
Right. So, picking up on a topic that we had discussed a few minutes ago when we were talking about the COVID vaccine, we had a couple of questions actually come in about that. And so one question is, do you know if there were any of the COVID vaccine trials that did not exclude people with prior cancer history? So there's a lot of people who are concerned about, should I take the COVID vaccine if I'm in active treatment, if I'm a cancer survivor, does it matter how many years out I am, So yes, please.
Well, I'm a cancer survivor, and I'm going to be taking it. I can be sure. I mean, so I think the issue is more what the current status of your immune system is, right? So, but I think specific studies would have to be done, perhaps in certain types of cancer patients. But most patients who've been through and completed their chemotherapy, their immune system recovers, and they should be perfectly good vaccine candidates. I think there should be some surveillance of certain patients, though, to make sure there's no untoward or unexpected effects. And the vaccines come in different formulations, as you know, and some of them may be more suitable to patients with perhaps suppressed immune systems versus patients who may have a history of cancer, but there's no reason to think their immune system isn't perfectly good for the purposes of raising antibodies and against COVID-19. Any comments on that, Debu?
It's hard to know exactly what the FDA is going to, how it's going to be approved, but most of us feel that as long as the safety data is pretty good, which it is, yes, there are allergic reactions, and yes, there may be long-term side effects that we don't recognize, but the safety profile looks pretty good and it looks effective. What we don't know about cancer patients is whether or not they're going to mount as good an immune response, as Matthew pointed out. But that, as long as it's safe, we can then track these patients and see how effective it is. The second thing is that the indications so far are that cancer patients may have more complications from COVID. We haven't been able to parse out whether it's early stage or not, whether breast cancer versus other cancers, but as a whole, the reports that have come out of both Europe and the US and China all suggest that cancer patients seem to be at more risk for complications. So if you put all that together, what makes sense is that if the vaccine is approved in general, that cancer patients should not necessarily be excluded. Now, there are some groups of patients that will be excluded or will need more testing. There's some controversy as to whether children should get the vaccine or not. And then finally, pregnant individuals, whether they should get the vaccine or not. And I think those are still things that are going to need to be sorted out. But in terms of cancer patients, I feel and hope, and certainly hope, that cancer patients will be cleared to receive the vaccine.
But the key thing to remember with these vaccination programs, you just need enough people to be vaccinated so that the virus can't propagate in the population. So if we can get to 70 to 80% of people with immunity, the virus will die out because it can't go anywhere. An infected individual, on average infects less than one person, and then your virus burden in the population gradually goes down. So I think if you're a healthy person, you should get vaccinated. If you're a cancer patient, you should try and encourage everyone around you to get vaccinated, even if you personally have decided that you want to hold off a little bit longer for safety or other reasons, or whatever your physician says. Listen to what the docs say. But I'm pretty optimistic with the efficacy of the vaccines. Between 70 and 90% will be out of this mess in 6 to 9 months, as long as people go ahead and get vaccinated.
So you're going ahead and booking your hotel room for San Antonio for next December then, right?
Yep. I always do it on the last day of the symposium. Actually, I just go to the hotel and say, "This see you next time next year. Put my name in the book." But of course, I can't do that this time. But I think we'll be all seeing each other. But what I would say is that the online format is definitely not going to go away, because, of course, and take this event, which is fabulous, by the way. We'll do it in person, but think about how many more advocates we can reach through this platform. You could have 3,000 or 4,000 advocates, as opposed to the 200 or 300 we typically have, or maybe it's a little bit less than that, isn't it? It's like 150 or something each year. We could actually reach many more people, and maybe also we could have virtual events through the year as opposed to just once.
No, that's absolutely right. So that's a whole nother conversation about how COVID has changed the way that we have meetings and we interact with each other. So, but let me go ahead and direct a question that came in to Dr. Oesterreich. So Lainey wants to know, she said she would love to hear you talk about taking or not taking aromatase inhibitors for over 5 years.
Yeah, I should say that as a PhD, I try not to answer direct clinical questions. I mean, as I mentioned, that I am very interested in nodular breast cancer, and there are more late recurrences in patients with ER-positive lobular compared to ductal cancer. So, one could imagine that some physicians would make decisions based on this. But again, I don't think I will comment on that, and maybe give that to Dr. Ellis and Dr. Tripathy, and maybe, you can comment on this as physicians.
Well, here's the deal. The deal is, for me, when you're looking at duration, remember, these trials are historic because of the length of time that we're talking about. Right? So, just like do a trial on the duration of endocrine therapy, and you're discussing a decade of treatment. Of course, you're going to be lose your hair and go grey like me when you're finally up there on the podium explaining your results. But in the earliest looks at extended endocrine, so there's this whole issue of 5 years. 5 years was a pretty arbitrary decision, and I don't want to relitigate why they settled on 5 years. But you had a whole bunch of patients who received 5 years of tamoxifen. So that when the aromatase inhibitors were approved as adjuvant therapy, as initial adjuvant therapy, they wanted to do some questions around switching from 5 years of tamoxifen to starting with aromatase inhibitor. And in the main, those trials did show a modest benefit of switching. But interestingly, continuing tamoxifen also showed a benefit. The problem is, with these hormonal drugs, is the nature of the disease, right? Luminal breast cancer, because you're not eradicating it with chemotherapy, the clones are in your body and they're gradually waking up over time, and there's a steady drip of relapses out to 15 to 20 years, and that pace of relapse is seriously suppressed with the endocrine therapy. But you sort of have to be on it to have that effect, with the sort of exception that there's something really weird about what endocrine therapy does, because when you stop it, not everybody starts relapsing. The curves, as we say, stay apart. But it does appear that switching to the aromatase inhibitor after 5 years tamoxifen is having an effect, maybe particularly in high-risk patients, as you'd expect. But then we had a whole bunch of patients after the aromatase inhibitors were approved who got to 5 years, and the question was what to do with them. And so, what we should have done is say, well, switch to tamoxifen versus stopping. That would have been a very interesting experiment. As far as I'm aware, that's never really been done. There's been trials of intermittent aromatase inhibitors, and there's just been plain Jane studies of continuing aromatase inhibitors. And the overall, I'm interested to see what Debu says, but those trials haven't been really as clearly showing a benefit as switching to aromatase inhibitor after 5 years of tamoxifen. But I think in higher risk patients, in a willing patient who's not having terrible bone problems, who is not having terrible hot flashes, is coping with the effect of the aromatase inhibitor, on their marital lives, then it's reasonable to continue it, but certainly for no more than 10 years. What do you think, Debu?
So I have a little bit of a different take on it. I agree with much of what you're saying. Hormone receptor positive breast cancer has a very long natural history. People with early stage breast cancer can recur 10, 15, 20 years later. And that's why we have looked at it more extended therapy. And generally what we have found is whether you use tamoxifen or an aromatase inhibitor, you do get fewer recurrences if you use more therapy, but it's a diminishing return. You get a bigger reduction in the first 5 years. The next 5 years, you get a little bit of a reduction. And part of it has to do with the biology. If you just look at the math, there's no way that cells can be continuing to divide at any appreciable rate and recur 15 years later. So that really brings up the concept of dormancy, cells that are asleep, that are not dividing. And there are now some animal models that do show or suggest that dormancy is a real feature. And there's a whole field of study now trying to understand what governs dormancy and what governs exit from dormancy. When do dormant cells now reawaken and start to divide? And it may be a totally different process that has nothing to do with the estrogen receptor. So I think we need to understand more about these late recurrences and what drives them. If you look at all the gene profiling assays that look at short-term recurrence, they're not very good at predicting long-term recurrence, and so the mechanisms are likely to be different. So I think we have to learn much more biologically. I think that just extending hormonal therapy is a blunt instrument, but in patients at very high risk, it's worth it. And I do recommend extended hormone therapy in patients with higher risk of breast cancers, node positive, for example. But as Matthew pointed out, you know, it really is not feasible in someone who's just had a really rough ride and a lot of side effects from 5 years. I just find it would be very difficult to ask someone to go another 5 years. So that's my thought on it.
Yeah, no, just maybe in a follow-up comment, I think there are some models out to look at dormancy, but I don't think they are great. I do think we need to have more studies on dormancy. Like you said, we don't even know at this point when is it driven by ER and when is it ER independent. Actually, I would like to curious, do you think there are assays out now which can differentiate between 5 and 10 years, whether you should take hormonal therapy longer? There are a lot of efforts, something which a lot of companies try doing, a lot of research is ongoing. Where are we with predictive markers for
well, I can run into trouble, answering this question because I helped develop one of the tests called Prosigna. But I can say that the one I'm about to say is also true for a test called EndoPredict, I think. So the issue is predicting risk in the 5 to 10 year window. And it turns out that, Oncotype, because if you think about it, if you've got a test that tells you you're very low risk over a 10-year period, if you take 5 years of the drug, you don't need to take any more, right? But that's purely a prognostic thing. You need a molecular classifier that does a good job of identifying low-risk breast cancer patients over 10 years. And it's well known that Oncotype, its predictability decays between the 5 and 10 year period, and some of these other tests do a better job at that, to the point where actually I've ordered the test at 5 years to make sure that this patient is low enough risk not to need extended endocrine therapy. Although that's not that's not what it says on the tin when you look at the sort of approved use for these tests. I think knowing what your risk is driving the decision of whether you need to take more drug. And so that's I'll sort of leave it at that. Debbie, any thoughts there?
Yeah, I agree with you. I mean, they do predict longer term recurrence. The breast cancer, the BCI is the one that has been studied the most with more data sets, looking at 5 years versus 10 years or 3 versus 6. But I think I think any predictive profiling assay will give you both short term and long term. But I think the long term is going to be maybe a little dirtier. It's sort of like the cone of uncertainty with a hurricane. The farther out you go, the more unpredictable a hurricane is in its course. There's more randomness that falls that enters into the whole equation there. But so far, I think like the BCI, the Breast Cancer Index, does seem to be predictive of benefit. But as Matthew pointed out, it may not be anything specific about longer versus shorter. It's just a risk. It's a risk assessment.
Yeah, prognosis is critical here.
Prognosis.
You've got a great prognosis. You can stop doing whatever you're doing and get on with your life.
Yeah.
And I guess there are some trials ongoing on targeting dormant CTCs as well, right? One from one coming out of Penn. So I think that from Angela de Michel, I believe. I guess.
Yeah,
well, I think classically you would say that an endocrine drug, its classic action is to induce dormancy. I mean, it induces a G0 state, and the cells just sit there.
But there seems to be
some of them don't survive long in that state, because otherwise the curves would come back together, right? But they don't. You are curing some people with endocrine therapy.
Yeah.
It's just not enough of them.
There's some data emerging from Lewis Chodosh and from Filippo Giancotti looking at inflammation pathways, the hippo pathway. There's some other pathways that are being invoked. I don't know much about that field. Steffi, you probably know much more about it than I do, but it may be a different set of mechanisms. There may be some overlap. I don't know.
Yeah, no, I think that trial actually has, Matthew, you can comment on this, had chloroquine at some point, right?
Yeah, but I don't think everyone should be on chloroquine, and if you know anything about chloroquine, you certainly wouldn't want to be. But I think it's a great area of research, right? Because there's all these investigators, amongst which was this guy from Germany, Braun, you remember, or Brown, doing bone marrow biopsies, and basically the bone marrow is where we think a lot of these EL positive cells are hanging out. Although initially, when they're in the bone marrow, they have a very odd characteristic. They're actually EL negative, and then only when they start to wake up and start growing again, they become EL positive. So there's all sorts of, this is Sean Zhang work of Baylor. So I think there's a lot of work to be done there. Of course, there, again, it's sort of what I was saying, you've got to persuade patients to have a bone marrow aspirate, which is not the most friendly thing to have on the planet, but it's an example where clinical investigation could probably take us forward. And there may be blood tests that will tell patients, like these hypersensitive liquid biopsy tests, that somewhere in your body, there's a cancer cell and you probably should be taking something. Now in my case, I take something called an ultra-sensitive PSA, and as long as I have undetectable PSA, I'm absolutely fine. But if I don't, I suppose I might have to think about doing something. So, you just live from test to test, which is another sort of aspect to a lot of this, the psychological morbidity of worrying about your health all the time. So, yep, that's kind of where that field is.
Okay, so there was a follow-up question on aromatase inhibitors. And they wanted to know, has anyone looked at natural aromatase inhibitors versus prescription?
I'm not aware of any studies, but there's a DIM, right? The diindolymethylcarbamol or whatever. That's sort of a natural aromatase inhibitor. I haven't seen any studies on that, though.
I haven't either.
I'm trying to think of what this product is. Is it? It's on the tip of my tongue, and I can't remember what this thing is. What the natural aromatase inhibitor? Just
Diindolymethylcarbamol, DIM.
I don't think it's that one. No, that's something in cabbages. There's something else that I think she's talking about.
Well,
there are natural versions.
We need to get back.
There are natural CYP19 inhibitors that are present in certain foodstuffs, and I've heard of this. And someone asked me this before a few years ago and came with a suggestion they could go on it. I think the question with those things, with those sort of dietary things that are natural CYP19 inhibitors, is it really doing what it's saying it's doing? So, because the problem is that it turns out that estradiol at low levels is quite hard to measure. The sensitive estradiol tests are quite difficult to be reproducible because you're looking at very low levels of estrogen in postmenopausal women. So there was a whole industry looking at estrogen levels, ultra-sensitive estrogen levels. And so if you were going to do something like that, I mean, ideally you want to know what you were doing was working. So you could theoretically go on a natural CYP19 inhibitor and measure your estrogen levels using one of these very expensive assays. But, those expensive ultrasensitive assays.
So I Googled it.
Not readily available.
I found flaxseed meal, white button mushrooms, quercetin.
Thank you.
Those are all natural.
The flaxseed was what I was thinking about, because this chap is a friend of mine who I haven't seen for a while, Paul Goss, wanted to do flaxseed studies. So yeah, flaxseed ground up into your bread is what they recommend if you want to take flaxseed. But I don't know how much flaxseed you would have to actually affect your systemic aromatization. which of course happens in lots of tissues in the body, right? Obviously, after menopause, your ovary doesn't do a lot of aromatization anymore, but it happens in, in your adipose tissue, for example, and can happen in other organs as well.
Maybe one thing I can comment, just hearing you talking about inhibition of CYP enzymes, and I should have mentioned this earlier, which I think is one of the more important presentations.
Why don't you explain what a CYP enzyme is, Steffi?
The CYP2D6. I don't know if you saw that presentation. But there's every year there are presentations at San Antonio on genetic changes in an enzyme, in one of these CYP enzymes, CYP2D6, which is involved in metabolizing tamoxifen, actually.
So these are cytochromes, right? Cytochrome P450 enzymes, and they're involved in metabolizing all sorts of things that you ingest, right? And they all have different specificities for different drugs and natural products in your body, and you need them to detoxify your body and activate hormones. Okay, so that's the explanation of what a CYP
specific is for tamoxifen, right? And I think every year at San Antonio there are presentation on that there are specific genetic changes which might affect how good tamoxifen works for you, how well it's metabolized. And there was one presentation this year, like a really big meta-analysis, and really, I think, somewhat concluding it to say that maybe there isn't very solid data there to say that these polymorphisms.
No, this was a big controversy about 5 years ago, and the bottom line is it probably doesn't matter because when you take tamoxifen at 20 milligrams, it turns out the half-life of tamoxifen is quite long. It's more than 24 hours. So you get a lot of accumulation of tamoxifen in your body at taking that dose. Partially that's why there's been interest in actually going into lower doses of tamoxifen to 10 milligrams, and a lot of the Italians have studied lower doses of tamoxifen for many years, and it's probably effective at a lower dose. But these CYP enzymes are really important because you saw a lot of drug combination studies at this particular meeting. Hey, let's do 3 drugs, and see if 3 drugs are better than 2 drugs, etc., etc. But they often run into these problems where one drug affects the metabolism of the other drug, and you end up with some very unfortunate side effects and problems and dose modifications, and that's because of this whole drug detoxification mechanism through these CYP enzymes. So it's a very complicated field of research, actually.
So we had another question about AIs. And Amy wants to know about cardiotoxicity for long-term aromatase inhibitor use.
Great question.
So, yeah,
do you want to get to that one first, Debu?
Sure. I mean, that was a concern initially with the aromatase inhibitor trials, as there seemed to be maybe an excess of cardiovascular deaths. And so the FDA took a really close look at this, and I think in the final analysis they found that that was not the case. However, what we do know is that with lower estrogen levels, you do tend to get higher cholesterol levels, and of course cholesterol, especially LDL cholesterol, and that does increase the risk of heart disease, of coronary disease. So, I think in general, when people do go on an aromatase inhibitor, well, first of all, when people go through natural menopause, their cholesterol levels tend to creep up because estrogen does tend to keep cholesterol levels down. And then when on an aromatase inhibitor, they drop even more, and we do sometimes see people's cholesterol levels drift up. So I think the prudent thing to do is to make sure that someone is being monitored for the known risk factors for heart disease, and that should be taken into account. But in terms of other causes of heart disease, like arrhythmias and that sort of thing, the final conclusion is that there's probably not a relationship with aromatase inhibitors.
Yeah, I agree with that. I mean, some of the data is it's possible that tamoxifen is mildly cardioprotective. So when you're looking at aromatase inhibitor than tamoxifen, it's more that you weren't getting the cardioprotective effect of tamoxifen that acts like a sort of mini estrogen, if you like. In some women at least, and that was sort of compounding the analysis. Generally speaking, when I'm prescribing aromatase inhibitors, I go through the full sort of cardiovascular health issues with the patient, make sure we know their fasting lipids, make clear on their statin if they need to be, emphasize exercise, and diet and weight control. The reason for that is the majority of women with ER-positive breast cancer survive their disease. They're more likely to die of heart problems than they are of breast cancer. So you're not being a good internist if you don't look at all the issues and support your patient to be on do the right things prophylactically.
Okay. So let's circle back to a question about immunotherapy. So Marjorie wants to know, should complete sequencing of patients' blood and tissue be standard practice prior to any use of immunotherapy? Why or why not?
What a great question. But it doesn't actually relate necessarily to immunotherapy. But let's pull this very, very important one apart, because I need the good advices of my co-discussants. So there's lots of different types of DNA sequencing you can do for a breast cancer patient, right? So the first kind of sequencing that came along is sequencing of what's called your germline DNA, the DNA you inherit from mum and dad that's in every normal cell of your body. And in the actionable genes from a breast cancer perspective there are BRCA1, BRCA2, and PALB2. And Susan Domchek, gave an absolutely tour de force conversation about whether you should actually measure those other 20-something genes. And she was kind of down on a lot of more esoteric gene testing because it's leading to the wrong kinds of decisions around prophylactic mastectomy and oophorectomy and stuff like that. But that's sequencing of germline. And you're looking for, I just mentioned 3 genes. Now, if you sequence a tumor, oh my gosh, those tumors are wildly complicated. They have hundreds of genetic changes of all types, deletions and gene copy gains, and point mutations, and chromosomal translocations. Cancer cells' genome is really messed up. So when you're doing that sequencing, you can interpret the test, the sort of sequencing in a variety of different ways. From the immunotherapy perspective, one of the things that you're looking for is, can you spot forms of DNA repair defect that might sensitize to immunotherapy? And there's some fairly esoteric, from the breast cancer perspective, forms of DNA repair defect that might be worth looking for. One's called mismatch repair. It's not very common, but it can occur in both triple negative and ER positive breast cancer, and it might render the tumor particularly sensitive to immunotherapy. So sometimes I'll do that in an advanced breast cancer patient to see if I can spot one of these. But and there's also a concept called tumor mutation burden. How many mutations does that crazy breast cancer have? Well, it turns out most breast cancers don't have the crazy number of mutations you see in things like bladder cancer and lung cancer and melanoma, which are all induced by external carcinogens like sunlight and industrial pollutants in your urine and tobacco smoke and other pollutants in the air you inhale. So breast cancer doesn't look like that, and tumor mutation burden is not that predictive of response to immunotherapy drugs, curiously, although it may be mildly predictive. And then the other reason you sequence breast cancers is to look for druggable mutations, because we're all familiar with one druggable mutation, that's HER2 amplification, where the chromosome 17 gets wildly abnormal and it makes lots and lots of sort of nested copies of the long on chromosome 17, and that leads to activation of HER2. And we've long sought other examples of that actually in breast cancer, and right now that's actually the only amplicon we're routinely targeting, although we're beginning to focus on a few others. But then, in addition to the amplifications, you're looking for point mutations, and that is where the Pi3 story comes in. And there's some other mutations that we discovered, like in the HER2 gene, can be non-amplified but mutant, and they respond to drugs. And there's a few other examples now we're tracking down, even deletions. We're actually chasing treatment for patients who've lost a copy or two of the neurofibromatosis gene, which I don't have to go into details on, but there's maybe a drug for those patients that's sort of repurposed from our experience in neurofibromatosis. So should everybody with metastatic breast cancer have tumor sequencing? I would say yes, but for lots of reasons, not just for immunotherapy. There may be other secret sort of occult therapeutic hypotheses that are useful and could come up from that effort. But I would say we're just really at the beginning of exploring the druggable genome, and that's a very, very active area of research. And I'll stop there, see what Debu thinks.
I do agree. I think that people with metastatic breast cancer who are interested, who are well enough to take different therapies and particularly interested in clinical trials should have their tumor sequenced. At the current time, as Matthew pointed out, most of the patients who end up getting their tumor sequenced, we don't use the information for anything. It doesn't point us to a drug. So it's still a minority of patients, but hopefully that number will grow. For example, HER2 mutations, normal HER2 copy number, these are HER2 negative by standard assays, but that now leads to a drug that is under FDA review, neratinib, which is effective, partially effective against these tumors. And so immunotherapy drugs now have been approved for anybody that has these mismatch repair, high tumor mutational burden that Matthew was discussing. Although in breast cancer that's not very common, but it does open the door to immunotherapy. But I would say that most of the things that we pick up through gene sequencing are for things other than immunotherapy, particularly targeted therapies, kinase inhibitors, things of that nature.
Yeah, I think I would like to add two things. One is, the one thing we have learned over the last decade is that the evolution of the tumor is just absolutely amazing. It really changes constantly. So I think in the perfect world, you would sequence the tumor, especially after progression, frequently, because it changes all the time. And would love to go into liquid biopsy and just look how the mutation change while the patient is on therapy. So I think the evolution is really, really stunning. The second thing is that, a lot of the current tests, and Matthew mentioned this, look at point mutations, but there's more and more the desire and the realization that the changes happen at other levels. It's not only these point mutations, but there are these structural variants. There are sometimes half or entire loss of chromosomes. Chromosome 16, I think Iketerin would be interesting to look at as well. And obviously the estrogen receptor, the fusion, right? Is a gene fused? Do we lose part of the estrogen receptor? So I think to hopefully either do, full genome sequencing or come up with better assays which cover other genetic changes, I think, in the future, and hopefully do it frequently.
So just to put a sort of end to your sentence there, Steffi, one of the things that has come out of my lab and Steve Carr's lab at the Broad Institute this year is a proteogenomic map of breast cancer. So the big problem when you've got that big nest of mutations is what are the downstream effect of all those mutations? What's the integrated effect on signaling? How do these things talk to each other? Well, the approach we've taken is actually to rescue the protein from making the DNA. Because when you make the DNA, typically the genomic person will take the cells, extract the DNA, and throw all the proteins out of completely of no interest. But basically we say, oh, just a minute, let me rescue those proteins, and then you can sequence the DNA. So we put the proteins into a machine called a mass spectrometer, which actually allows you to look at all the proteins. We can detect over 10, 11, 12,000 proteins and up to 30 to 40,000 phosphorylation sites, from a piece of tumor, half the size of my thumbnail. And so that gives you an entirely new view of what the tumor's doing. So if you're really interested in what I'm saying, you can find that paper in Cell that came out last week. And we're still scratching our heads and trying to work out what it means. But, in our world, AI doesn't mean aromatase inhibitor. It means artificial intelligence. We're using a lot of high-level computation and cloud computing to try and basically get to what I was saying earlier, getting to a better diagnosis for each individual patient.
Matthew,
I think that's...
Just very quickly, you'll be delighted to hear that it's a topic, it's a paper in our next journal club.
Well, good luck. I think it'll take 3 journal clubs to get through it.
No, I think that's really fascinating, Matthew, what you guys are doing, you know, the omic look at things, you know, the whole ApoBec signature thing, which is all post-DNA, you know, it's mRNA editing. And we tend to think that DNA is everything, but it certainly is not. There is a lot going on that is not at the DNA level. And it really calls for us to be looking at the whole kit and caboodle, the whole omic pile.
Yeah. Which I think is a reason in liquid biopsies not only to look at circulating DNA, but actually look at the cells which are there, so you can look, like Matthew said, to look at the proteins, to look at the RNA. Yeah.
Okay.
Yeah, I was going to say, interestingly, a couple of weeks ago, I gave a talk at the University of Utah on the intersection of advocacy and omics. So this is an area that advocates are becoming more versed in. We're much more interested probably than ever before in the omic revolution, if you want to use the cliche term. So we're on your side.
I just wanted to follow up on that because, you know, when we're trying to develop, you know, a better look, build a better microscope, and in actual fact, to do that, we need the sample to be collected slightly different the way it's normally collected, because we need them to capture all that exquisitely complicated biochemistry. We need to have them snap frozen, right? Can't have them pickled in formalin. And so basically we've developed this thing at Bayer called abeyance pathology, where the woman accepts she's going to have an additional biopsy, and that's going to be snap frozen. Now we do section it to make sure there's no diagnostic information there for standard thinking. But then we're running the new diagnostic platform in parallel with the old-fashioned one and seeing what the new one can do. And eventually, obviously, we want to be able to tell the patient and her doctor the results of that testing, but we can't tell the patient and the doctor the results of the testing if we don't know what it means, right? So that's kind of where exactly what you're touching on is so much of this new omics asks a lot of patients. We need an extra sample, but it's amazing to me how generous women are and how the advocacy community has really embraced this whole idea of working with patients, because in the end, you know, the best model for humans with breast cancer is humans with breast cancer, right?
Right. Well, I've gotten the notice that we should start wrapping things up. So any final words from our mentors?
Thanks for doing this. I think this is great. Like I said, you know, it's one of the highlights every year at San Antonio. I think this is a great program, and I'm happy to be part of this.
I want to, first of all, thank the organizers of this long-standing event. I've been fortunate enough to do this for, I think, more than 10 years now, and I learn a lot from the questions. And I think all of us do. It makes us think a little bit differently. And some of the comments I hear from our advocates and from people that aren't thinking the way we do about science, but are thinking almost in a more free mind, can come up with some insights that I wouldn't have thought of. So just sitting here and explaining this to you, I find to be very helpful. It's almost a selfish thing to do, even though we certainly appreciate donating our time to teach, but we're getting something out of it too. So I'm very appreciative of the thoughtfulness and the questions that we get, and it's a pleasure doing this every year.
Thanks, everybody. Stay well, and looking forward to seeing everyone next year.
Yeah, so I just wanted to thank all of you for a wonderful session. So a special thanks to our mentors today, Dr. Steffi Oesterreich, Dr. Debu Tripathy, and Dr. Matthew Ellis. And I will also tell you that you guys have a huge fan club. So they've been writing in just accolades to all three of you. So anyway.
That's great. Thank you.
We're very grateful
if
for
we
your
could,
time.
we would write back and send them accolades in return. How about that?
But we truly enjoyed hearing your thoughts on the day's events. and the events, across San Antonio and beyond. So this is our last advocacy event for the 2020 San Antonio Breast Cancer Symposium. We hope that all of you will join us in San Antonio for next year's meeting, which will be December 7th through 11th, 2021. So make your hotel reservations now. And we hope to see you all again soon. So thank you so much to our mentors, and thank you to our sponsors and our viewers, of course. All right.
Great. Thank
Bye,
you.
everyone.
Thanks.
Bye.
Bye, everyone.
wine can prevent cancer, or does it cause cancer?
I don't think this video is about scolding those people that love and care and those people that have misstepped with their words.
Have you tried yoga? Yeah, I have.
I think this is really about the MBC community having a good laugh.
Have you swam in Lake Tiki Taka? Tiki Taka?